important class of internal capsule. You know the brain is nothing but the consists of gray and white matter. You all know the gray matter forms the cell bodies, nucleus, and the white matter forms the fibers. That is called white fibers of the cerebral hemisphere, the brain. White fibers of the brain. You know the three types of white fibers in the present in the brain. Kiki? Association fibers. It connects the different gyri of same hemisphere, that is called association fibers. And when the fibers interconnect to both the hemisphere, a particular area of the same different cerebral hemisphere, it is called commissural fibers. You know the corpus callosum? Have you have all seen the corpus callosum? It is a largest commissural fibers in the brain. Now another fibers is there. Number one is association. Second is the commissural. Third is projection. The projection, this denotes that it projects from one area to another area. That is, the most important part of the brain is the cerebral hemisphere. So from cerebral hemisphere, it is projected to the another parts of brain, that is brainstem and medulla and also the spinal cord. Spinal cord is a part of central nervous system. The parts of central nervous system when connected with each other by projection fibers. So this important projection fibers is the internal capsule. Why internal? It is a white fibers. Actually, this internal capsule is a compact band-like structure. Compact band of projection fibers. Projection মানে কি? From the cortex to brainstem, then after brainstem it goes to the spinal cord, and also some ascending fibers is there. So these descending fibers, it is called motor fibers or centrifugal fibers of the internal capsule. Like a band of projection fibers. একটা narrow part দিয়ে অনেকগুলো fibers goes towards the cerebral cortex and from cerebral cortex to the brainstem. So these descending fibers is known as motor fibers, and ascending fibers, you know, different sensory impulses there. So these impulses are conducted by the sensory fibers, that is ascending fibers. Centripetal fibers, two different sensory cortex of or visual different cortex of the different parts of the cortex. Okay. Internal capsule can be seen only in a typical horizontal section of cerebral hemisphere. When you cut the brain or cerebral hemisphere at the level of interventricular foramina, you know the foramen of Monroe is there between the third and lateral ventricles and pineal body. If you cut this section, you will get the internal capsule. So internal capsule is closely related to the some parts of the basal nuclei and diencephalon, the parts of diencephalon, that is thalamus, dorsal diencephalon. So if you draw a picture of internal, the horizontal section, অনেক বড় করে আঁকলাম, a big So this part is internal capsule. It is the head of corded nucleus. You know the basal nuclei is consist of corded nucleus and lentiform nucleus. Claustrum is there. So this part is head of corded nucleus and this is thalamus. And this is the globus pallidus and this is the putamen, the part of lentiform nucleus. Then another white matter is there. This white matter. And then again claustrum is there. Claustrum. And very good. Extreme capsule. This is insula. This is insula. This is extreme capsule. This part is called extreme capsule. So it is located internally to the lentiform nucleus. So it is called internal capsule, and external to the lentiform nucleus, external capsule. So it is called internal capsule. Another name is internal capsule because it is related to the internally of the lentiform nucleus. This picture is nothing but it is a horizontal section of the cerebral hemisphere, and it is located in the inferomedial surface of the cerebral hemisphere. Is cerebral hemisphere. Internal capsule is cerebral hemisphere. Now the extent of cerebral hemisphere, extent of internal capsule. What will be the extent? Upward continuation and downward continuation. Upward continuation of the internal capsule. Suppose this is internal capsule. So above it spread out like a fan and it forming it continuous as corona radiata. Corona radiata is also an important projection fibers. It continuous with the corona radiata above in the cerebral hemisphere towards the cortex, and below this part, you know the connection between the midbrain and the diencephalon or cerebral hemisphere. What is this? The connection between the midbrain and the cerebral hemisphere. Connection between the midbrain and the cerebral hemisphere. Cerebral peduncle is there. So this cerebral peduncle, it continues downward at the base of the cerebral peduncle. That is called crus cerebri. Crus cerebri as a continue hobe, crus cerebri. না হলে brainstem আসবে কি করে? Spinal cord যাবে কি করে? So this is the extent. দেখতে কেমন? মানে the shape of the internal capsule. It's not a straight line. It is not a straight line. It is bend. কেন bend? Due to this lateral concavity. Due to the lentiform nucleus. Convexity of the lentiform nucleus, it bends like a V. Genu, that is called genu, but it is bent like a V. If you, this V. Or you may call it like L letter. L. So the parts of this part, so when the shape is like a L letter, the part is the anterior limb, medially head of corded nucleus and laterally the putamen, lentiform nucleus. This is the anterior limb. From here to here, anterior limb. The bend between this is posterior limb, Savabik, and naturally this is a posterior limb. The bend between the posterior limb and anterior limb, it is called genu. Genu. আরেকটা genu কোথায় পেয়েছো? Genu of corpus callosum. যে কোনো bend venu. Genu is a bend. It is nothing তাহলে এই হেড অফ কডেড নিউক্লিয়াস এটা একটা সি শেপেড এরকম হয়, আমরা তো এটা এক সেকশন এঁকেছি, অ্যাকচুয়ালি এরকম হয়, এরকম হয়ে এরকম টেল হয়ে চলে আসে, এই টেলে অ্যামিগডালা থাকে। এই যে কডেড নিউক্লিয়াস, হোয়াট ইজ দ্য ফাংশনস অফ দ্য কডেড নিউক্লিয়াস? অ্যাকচুয়ালি ইজ পার্টস অফ বেসাল নিউক্লিয়াই, কিন্তু কডেড নিউক্লিয়াস কি করে না, ইট সেপারেটস দ্য ইন্টারনাল ক্যাপসুল ফ্রম দ্য সি শেপেড ল্যাটারাল ভেন্ট্রিকল। ল্যাটারাল ভেন্ট্রিকল থেকে সেপারেট করে রেখেছে ইন্টারনাল ক্যাপসুলকে দ্য কডেড নিউক্লিয়াস। আর এখানে আমরা একটা সেকশন এঁকেছি, তাহলে আমরা কটা পার্ট বললাম? অ্যান্টেরিয়ার লিম এল, জেনু, পোস্টেরিয়র লিম, and another part, this part is called why retrolentiform? Because it is behind, the retro means it's behind the lentiform nucleus. আমি আবার বলছি, the relation of the internal capsule according to the lentiform nucleus and coded nucleus, maximum the lentiform, so that this is the retrolentiform. Another term কোথায় সেটা? Internal capsule is very very important in theoretical question. তাহলে কি হলো? anterior limb, then genu, then posterior limb, then retrolentiform part, then sublentiform part. সাব, এখানে সাব দেখতে পাচ্ছি, you cannot see the sublentiform part in horizontal section of the cerebral hemisphere. If you cut the coronal section of the cerebral hemisphere, you will see the sublentiform part of the internal capsules. এই পার্ট গুলো কেন করা হয়েছে? Why this part is so important of the internal capsules? মানে তো থাকবে, তার মানে ডিফারেন্ট পার্টস, ডিফারেন্ট ফাইবার্স গিভ প্যাসেজ, ডিফারেন্ট পার্টস, সব পার্টে সব যাবে না। তাহলে পার্টস হয়ে গেল, তাহলে লোকেশন মানে এর রিলেশন কি? হোয়াট ইজ দ্য রিলেশনস অফ ইন্টারনাল ক্যাপসুলস? মিডিয়ালি হেড অফ কডেড নিউক্লিয়াস এন্ড থ্যালামাস, and laterally the lentiform nucleus. Very good. The lentiform nucleus again, globus pallidus and putamen is there. Okay, this is the relation. তারপরে স্টেপিং এ আসছে পার্টস হয়ে গেল, রিলেশন, লোকেশন হয়ে গেল, ইম্পর্টেন্ট ফাইবার্স। ফাইবার্স, what is the fibers? That is the constituent, the component of internal capsule, very important. From the first you consider the motor fibers. Motor fibers, you know the four lobes is there. খুব ভালো করেছে, কিন্তু আগে পড়ে নিয়েছি, আবার পড়বে, আবার ভেরি গুড। না সেটা পরে আসছে, ওইগুলো বলিস না, ওইভাবে নয়। ফার্স্ট ইজ you know the cortex very well, cerebral cortex, four lobes, frontal cortex, occipital cortex, parietal cortex and temporal cortex is there. From the cortex, all the fibers in four cortex আসবে কোথা দিয়ে? Through internal capsules, it coming into the brainstem and as well as in spinal cord. So this four হচ্ছে, তুমি জানো, শুধু পন্টাইন যোগ করে দাও, frontopontine, parietopontine, occipitopontine and temporopontine. This is the corticopontine fibers. It is the largest component of the internal capsules, this corticopontine fibers. And according to the name, frontopontine, parietopontine, occipitopontine and temporopontine. It is the largest. And যত internal capsules size দেখিস, 2/3 of the internal capsule is formed by these corticopontine fibers. 2/3, তাহলে 1/3 বাকি। এটা আমি বলছি মোটর ফাইবার্স, মোটর সেন্সরি আছে। anterior limb of the internal capsule, the fibers, white fibers, that is frontopontine fibers, through this capsule, through this part of the capsule. ক্যাপসুল দেখেছিস? ক্যাপসুল খাস? এই ক্যাপসুলটা ভাবনা, ক্যাপসুলের অ্যান্টিরিয়ার পার্ট দিয়ে চলে যাবে ফ্রন্টোপন্টাইন, প্যারাইটো এন্ড অক্সিপিটোপন্টাইন পোস্টেরিয়র লিম্ব, অলসো জেনু। ফ্রন্টোপন্টাইন জেনু দিয়েও যাবে, অ্যান্টেরিয়র লিম্ব অ্যালং উইথ দ্য জেনু, পোস্টেরিয়র লিম্ব প্যারাইটো অক্সিপিটো, তাহলে রেট্রোলেন্টিফর্ম ফ্রন্টোপন্টাইন অক্সিপিটোপন্টাইন। কিন্তু ইম্পর্টেন্ট এখানে দেখতে পাচ্ছি না সাবলেন্টিফর্ম পার্ট, it is give passage of temporopontine fibers of the cortex, যেটা সাবলেন্টিফর্ম পার্ট দিয়ে যাচ্ছে টেম্পোরোপন্টাইন, that is sublentiform, sublentiform. What is the functions of the diencephalon? So many, the hypothalamus, thalamus, meta, epi, subthalamus, there is so many nucleus is there, anterior, posterior, lateral, আবার সেটাকে ভেঙেছে ভেন্ট্রোমিডিয়াল, ভেন্ট্রোল্যাটারাল, বহু নিউক্লিয়াস, যেটা ভালো করে মুখস্থ করে নিবি। আর থ্যালামাসের কাজ কি? আর একটা জাংশনের মতো কাজ করবে, রিলে স্টেশন, রিলে স্টেশন। যেমন ধর বোলপুর জাংশন, এখান দিয়ে সব ট্রেন রিলে করবে, যাবে, অল দ্য ট্রেনস, এটাকে রিলে স্টেশন বলা হয়। থ্যালামাস থেকে যখন কর্টেক্সে যাবে তার নাম কি হবে? ডিসেন্ডিং, সবসময় মনে রাখবি ডিসেন্ডিং ফাইবার্স আর মোটর ফাইবার্স, কারণ ইফারেন্ট ফাইবার্স, ইট ইজ কামিং ফ্রম দ্য সেরিব্রাল কর্টেক্স, কখনো মেস আপ করবি না ডিসেন্ডিং ফাইবার, মোটর ফাইবার সবসময় ডিসেন্ডিং হবে। তারপরে কি রয়ে গেল? তারপরে বাকি এটা কর্টিকোপন্টাইন হয়ে গেল। তারপরে এবং এই পন্টাইন ফাইবারস গুলো কোথায় এ করবে, কোথায় টার্মিনেট করবে? ইন হুইচ পার্ট? পন্টাইন নিউক্লিয়াই। The cell bodies are present in the cerebral cortex, then fibers comes out from the cell bodies and it terminates into the pontine nuclei. Once পড়ানো হবে, so many pontine nucleus is there, অনেক pontine nuclei আছে, হয়ে গেল। তারপরে হলো ইম্পর্টেন্ট মোটর ফাইবার্স, কি? কর্টিকো নিউক্লিয়ার, প্রথমে কর্টিকো স্পাইনাল বলবি না, কর্টিকো নিউক্লিয়ার। কর্টিকো নিউক্লিয়ার, এটা আমি করে দিচ্ছি, কর্টিকো নিউক্লিয়ার কথাটা মানেটা কি? ধারণা না, ইউ পিঙ্ক 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 পাস, কর্টিকো নিউক্লিয়ার। What is the significance of this name? এই নেমেই তো লুকিয়ে আছে ওদের ফাইবারস গুলো। কর্টিকো নিউক্লিয়ার, ভেরি ইজি। কর্টেক্স, কর্টিকো, কর্টিকো মিন্স কি? যে কোনো কর্টিকো যখনই বলবো আমি, when I tell the cortico, it is related to the cortex, cortico. Then nuclear, nuclear mean nucleus, তাহলে you know there are so many nuclei, cranial nerve nuclei in the brainstem from 3rd to 12th, so সেগুলো তো মোটর নিউক্লিয়াই, মোটর নিউক্লিয়াই, cranial nerves, the motor nuclei, সেন্সরি বলবি না, মোটর নিউক্লিয়াই of the cranial nerves কে টার্মিনেট করবে? কর্টিকো নিউক্লিয়ার ফাইবার্স, কর্টিকো নিউক্লিয়ার ফাইবার্স। বস, কর্টিকো নিউক্লিয়ার means, nuclear means from the cortex to the motor nerve nucleus of the cranial nerve, from 3 to 12. But very interesting, in opposite side, not in the same side, not ipsilateral side, এটা মাথায় রাখতে হবে। কর্টিকো নিউক্লিয়ার ফাইবার্স যেমন আমার রাইট সাইডের ফ্রন্টাল কর্টেক্স থেকে বা প্যারাইটাল কর্টেক্স থেকে, এটা যাবে লেফট সাইডের মোটর নার্ভ নিউক্লিয়াস, এটা মানে কন্ট্রাল্যাটারাল হবে, এরকম ডেকাসেড হয়ে যাবে। সেম মোটর নার্ভ নিউক্লিয়াই কিন্তু নয়, corticonuclear fibers, and these corticonuclear fibers are present in the genu corticonuclear fibers genu. So this is genu দিয়ে কি যাবে, corticonuclear fibers. তাহলে এবার বাকি রয়ে গেল কি, যেটা আমরা বলি পিরামিডাল ফাইবার্স। দেখবি সবসময় বারবার পিরামিডাল ফাইবার্স এন্ড এক্সট্রা পিরামিডাল ফাইবার্স। তাহলে পিরামিডাল ফাইবার্স কি কি? কর্টিকোস্পাইনাল ফাইবার্সটাই পিরামিডাল ফাইবার্স, কিন্তু ইম্পর্টেন্ট আছে, কর্টিকোস্পাইনাল এটা ইম্পর্টেন্ট পিরামিডাল ফাইবার্স। থ্রু পিরামিডস, যখন মেডালা দেখবে পিরামিডস এর মধ্য দিয়ে যায়, থ্রু পিরামিডস। অ্যাকচুয়ালি ফাইবারস গুলোর জন্য এলিভেশন হয়েছে, পিরামিডস তৈরি হয়েছে। দিস কর্টিকোস্পাইনাল ফাইবার্স কামিং ফ্রম দ্য কর্টেক্স, দেন ইট ব্রেনস্টেমে আসবে, তারপরে এটা কোথায় যাবে, ইট গোজ টু স্পাইনাল। এটা নেম তখন চেঞ্জ হয়ে যাবে ল্যাটারাল স্পাইনোথ্যালামিক ট্র্যাক্ট আফটার দ্য লোয়ার মেডালা। ল্যাটারাল স্পাইনোথ্যালামিক ট্র্যাক্ট, স্পাইনোথ্যালামিক ট্র্যাক্ট কোনটা? ডিসেন্ডিং তো আছে, স্পাইনোথ্যালামিক বললাম। কর্টিকোস্পাইনাল হচ্ছে মোটর ফাইবার, এটা হচ্ছে তোমার অ্যান্টিরিয়ার স্পাইনো। আমি বলবো এটা টার্মিনেট করবে ইন দ্য অ্যান্টিরিয়ার হর্ন সেলস অফ দ্য স্পাইনাল কর্ড, দ্যাট ইজ দ্যাট ইনারভেট দ্য স্কেলিটাল মাসলস। কেন বলছি, কারণ দ্য কর্টিকোস্পাইনাল ফাইবার্স ফর দ্য আপার লিম, ট্রাঙ্ক and lower limb, anterior 2/3 of the posterior limb. The corticospinal fibers for the upper limb, trunk and lower limb. This order it is present in the basis peduncle, মানে cerebral peduncle of the বা crus cerebri of the midbrain. এই অর্ডারেই থাকে। প্রথমে থাকবে হেড, হেডের কি হলো, হেড হয়ে গেল কর্টিকোনিউক্লিয়াস। তারপরে চলে আসবো আপার লিম, দ্যাট ইজ আর্ম, হ্যান্ড, যা আপার লিম্বে থাকবে মাসলস। তারপরে ট্রাঙ্ক মাসলস, তারপরে লোয়ার লিম অ্যাকর্ডিং টু দ্য লেগস, পেরিনিয়াম। দ্যাট ইজ দিস অর্ডার ফ্রম অ্যান্টিরিয়ার টু পোস্টেরিয়ার। তাহলে সেটা থাকবে কোথায়, অন দ্য পোস্টেরিয়ার লিম। তাহলে পোস্টেরিয়ার লিম্বে আর কেউ থাকে, দ্য কনস্টিটিউয়েন্ট ফাইবারস অফ দ্য পোস্টেরিয়ার লিম থাকে। এক্সট্রা পিরামিডাল ফাইবারস, দেখা গেছে some of the fibers from the cortex to a subcortical gray matter. Subcortical gray matter, they are also part of the gray matter. কি কি হতে পারে তারা কি কি হতে পারে? red nucleus, very good, corpus striatum, substantia nigra, olivary nucleus, so many subcortical gray matter is there. From the cortex সাবকর্টিক্যাল গ্রে ম্যাটারে আসবে। সাবকর্টিক্যাল, এই ভাষাটা বলতে হবে, সাবকর্টিক্যাল গ্রে ম্যাটার। এই সাবকর্টিক্যাল গ্রে ম্যাটারে যেগুলো আসে, they are not the constituent of the pyramidal fibers or pyramidal tract, they are the extra pyramidal fibers, they are also accompany these pyramidal fibers. সেটা থাকবে on the posterior 1/3 of the posterior limb of the internal capsule, namely from cortex to the red nucleus, rubrospinal. এটা আবার রেটিকুলারও আছে, রেটিকুলামেও আছে, রেটিকুলার ফর্মেশন। from cortex to the substantia nigra, corticonigral, so many. From the olivary nucleus, corpus striatum যেটা আসছে সেটা হচ্ছে corticostriatal fibers, এবং রেটিকুলামে যেটা আসছে corticoreticular fibers. They are the extra pyramidal fibers that is present on the internal capsule of the posterior limb. Then retrolentiform part, সাবলেন্টিফর্ম পরে বলছি। রেট্রোলেন্টিফর্ম পার্ট কোন ফাইবারস যাবে? সেখানে তো যাবে টেম্পোরোপন্টাইন যাবে, রেট্রোলেন্টিফর্ম সরি প্যারাইটোপন্টাইন অক্সিপিটাল। আমি বলছি এবার সেন্সরি ফাইবারস। হ্যাঁ, অডিটরি রেডিয়েশন, ভেরি গুড। কিভাবে? হাউ? If you draw a picture, দেখ তোকে মকবুল ফিদা হোসেন হতে হবে না, মকবুল ফিদা হোসেন হওয়ার দরকার নাই অ্যানাটমিতে। স্কিমেটিক ডায়াগ্রাম, তোমাকে কেউ বলতে পারেনি যে একদম সুন্দর করে পিকচার ড্র করো। ইউ ডোন্ট নিড এনি মকবুল ফিদা হোসেন হওয়ার দরকার নেই। বা আরো সব বল না, পেন্টার, আরো পেন্টারের নাম বল না। পিকাসো, লিওনার্দো, আরো আমাদের বাঙালির বল। হ্যাঁ, না আরো আছে, আমি এই মুহূর্তে নামটা ভুলে যাচ্ছি। বেঙ্গলি পেন্টার ইজ দেয়ার, অনেক ভালো ভালো। কি করছি আমি এগুলো? কি আঁকলাম? এটা ফুলের মতো। এই যে সেন্সরি ফাইবারস, সব অল দ্য সেন্সরি ফাইবারস রিলেট ইনটু দ্য থ্যালামাস। আফটার দ্য থ্যালামাস it comes into the cortex. That fibers is called thalamocortical. From the thalamus to the cortex. নাম দেওয়া আছে কি? আরে এইগুলোই তো নাম দেওয়া আছে। থ্যালামো, থ্যালামাস থেকে, কর্টেক্সে বলে কর্টিক্যাল। আবার যদি কর্টেক্স শুরু হতো তখন বলতাম কর্টিকো। একইভাবে কর্টিকো থ্যালামিক, কর্টিকো থ্যালামিক। রেসিপ্রোকাল ফাইবারসও আসবে সেন্সেশনের জন্য। থ্যালামোকর্টিক্যাল, থ্যালামাস নিজেও কিছু কাজ করতে পারে, ইটস ওন কিছু কাজ করতে পারে। তাহলে এই যে ফাইবারস গুলো অ্যাকচুয়ালি ইট রেডিয়েটস, রেডিয়েটস, ইট ইজ কল্ড থ্যালামিক রেডিয়েশন, থ্যালামিক রেডিয়েশন। This is called anterior thalamic radiation. It comes into the frontal cortex. It is the superior, it is comes into the sensory cortex of the frontal and parietal lobe. This is posterior radiations, that is occipital lobe, and this is the inferior thalamic radiations, that is auditory radiations in the temporal, auditory area of the temporal lobe. কত নাম্বার? 41, 42। কোথায় যায় ওটা? ভেরি গুড, অনার্স মার্কস। হেসেল জাইরাস, সুপিরিয়র টেম্পোরাল গাইরাস, জাইরাস বললি, গাইরাস বলতে, গাইরাস, হেসেলস গাইরাস, নেম ইজ অ্যাকর্ডিং টু দ্য হেসেল, হেসেল গাইরাস। নামটি বড় মধুর, EHS CHL অ্যাপোস্ট্রফি এস, হেসেলস গাইরাস। তাহলে এই পোস্টিরিয়রটা কোথায় যায়? পোস্টিরিয়র থ্যালামিক রেডিয়েশন ইজ নোন as very good, optic radiation. It comes into the visual cortex. এই ভিজুয়াল কর্টেক্স এর নাম বলতে পারবি? ঠিকই বল বল বল, ঠিকই বলেছিস। সালকাস কিন্তু একটা নাম আছে। হ্যাঁ, visual cortex, visual cortex is present in the which lobe? Which cortex? Which lobe? আরে collecting from sides হবে না, collection, which cortex? এগুলো মাথায় রেখে দিতে হবে। আরে occipital lobe, remember it, the empty khata, if you submit the empty khata, no written on this khata or book, no answer, no number, and no pass. It is called white line of Gennari. White stria in the occipital cortex. Now area number 17, 18, 19. ওখানে আবার ভিজুয়াল অ্যাসোসিয়েশন এরিয়াও আছে ভিজুয়াল কর্টেক্সে। ভিজুয়াল ফাইবারস বলা হয়, ভিজুয়াল ফাইবারস, আবার অডিটরি ফাইবারস। দ্য অপটিক রেডিয়েশন কামিং ফ্রম, দাঁড়া কটা বাজে, 9:50, 9:15 এসছি আমি, 9:13 বা 14 এসছি। তাড়াতাড়ি বল, তাড়াতাড়ি, এখনো দেরি আছে, অনেক জিনিস বলা হলো না। সেরকম আর কিছু নেই না, ক্লিনিক্যাল ইম্পর্টেন্স বলতে পারবি না তো। ফ্রম দ্য ল্যাটারাল জেনিকুলেট বডি অফ দ্য থ্যালামাস থেকে ল্যাটারাল জেনিকুলেট বডি হয়ে ইট কামস ইনটু দ্য কোথায়, ভিজুয়াল কর্টেক্স। দ্যাট ইজ কল্ড অপটিক রেডিয়েশন। ফাইবারস তো রেডিয়েট করে, রেডিয়েশন বলা হয়। অডিটরি একই, মিডিয়াল জেনিকুলেট বডি, the cell bodies in the medial geniculate body, then fibers comes out from this cell bodies of the medial geniculate body. Medial, MGB, that is the inferior thalamic radiation, comes into the auditory cortex in the temporal lobe, that is Hessel gyrus. হয়ে গেল। আর কিছু আছে? সাবলেন্টিফর্ম পার্ট, যেটা এখানে দেখা যায় না, সেটা তো আমরা বলেই দিয়েছি, টেম্পোরোপন্টাইন ফাইবারস এন্ড থ্যালামোটেম্পোরাল এন্ড টেম্পোরোথ্যালামিক ফাইবারস যাচ্ছে। আরো কিছু ফাইবারস আছে, এগুলো দেখে নিবে, অনেক ফাইবারস আছে, এগুলো ইম্পর্টেন্ট ফাইবারস। এবার হচ্ছে আর্টেরিয়াল সাপ্লাই অফ দ্য ইন্টারনাল ক্যাপসুল। আর্টেরিয়াল সাপ্লাই অফ দ্য ইন্টারনাল ক্যাপসুলস কি হবে? আচ্ছা, why any minor injury of the internal capsule, it gives a largest clinical outcome. Why? Because all the sensory and motor fibers are compact with each other. একটা ধরো এটা একটা ন্যারো গেট দিয়ে 100 স্টুডেন্টস আর কামিং আউট, সম্ভব না। বলে একজনকে চেপে দিলে 5 ক্র্যাশ হয়ে যাবে, এইরকম সামান্য ইয়ে। এবং মোস্ট অফ দ্য কমন, মানে এই যে ইন্টারনাল ক্যাপসুল আমরা বলি যে হেমিপ্লেজিয়া, এ পেশেন্ট কামস টু ইউ, এ পেশেন্ট কামস টু ইউ উইথ কন্ট্রাল্যাটারাল হেমিপ্লেজিয়া, মানে রাইট সাইডের হেমিপ্লেজিয়া, অ্যালং উইথ দ্য লস অফ স্পিচ হতে পারে। কারণ কি, তার মানে ব্রোকাস এরিয়াজ ইন্টারাপ্টেড হয়েছে, অ্যালং উইথ দ্য কর্টিকো স্পাইনাল এন্ড কর্টিকো নিউক্লিয়ার ফাইবারস। আবার কিছু পেশেন্ট কামস টু ইউ উইথ দ্য ফেসিয়াল প্যারালাইসিস, আপার মোটর নিউরন, আর লোয়ার মোটনে চলে গেলে সেটা হচ্ছে স্পাইনাল কর্ড, অ্যালং উইথ দ্য লেগ। ধর অনেকের দ্য আপার লিম ইজ স্পেয়ার্ড, এনি স্ট্রোক, এনি আপার লিম ইজ স্পেয়ার্ড, এনি হেমারেজ, বাট লোয়ার লিম ইজ প্যারালাইজড, এটা হতে পারে। এর কেন হয় এইটা ইম্পর্টেন্ট জানতে হবে। একটা পদ হয়ে বলে দিচ্ছি, কর্টিকো পন্টাইন সেরিবেলার পাথওয়ে। কর্টেক্স থেকে পন্টাইন এলো ইপসিল্যাটারাল পন্টাইন নিউক্লিয়াই, বাট ফ্রম দ্য পন্টাইন টু সেরিবেলাম এটা অপোজিট সেরিবেলামে চলে যাবে থ্রু মিডল সেরিবেলার পেডাঙ্কেল। অপোজিট কর্টিকো পন্টো সেরিবেলার, ইট ইজ হাইলি ডেভেলপড ইন ম্যান। এটা ইম্পর্টেন্ট একটা ট্র্যাক। কর্টিকো কর্টেক্স থেকে পন্স থেকে সেরিবেলাম, কর্টিকো পন্টো সেরিবেলার পাথওয়ে। আর আমি যেটা বলছি যে এই যে পিরামিডাল ফাইবারস অলওয়েজ ডেকাসেটস, সেই জন্য যদি পিরামিডাল, যদি পোস্টেরিয়ার লিম্বে কিছু হয়, ইফ দেয়ার ইজ এ দ্য পোস্টেরিয়ার লিম্ব ইজ অ্যাফেক্টেড, তাহলে কি হতে পারে? প্যারালাইসিস অর হেমিপ্লেজিয়া, কন্ট্রাল্যাটারাল সাইড অফ হেমিপ্লেজিয়া, কন্ট্রাল্যাটারাল সাইড। যদি রাইট মানে ইন্টারনাল ক্যাপসুল হয়, তাহলে লেফট সাইড অফ দ্য বডি হেমিপ্লেজিক হয়ে যাবে। কেন? এইবার সেটা একটা ইম্পর্টেন্ট হচ্ছে ব্লাড সাপ্লাই। তোমরা জানো three cerebral arteries supply along with the anterior choroidal artery, আবার internal carotid ও আছে, posterior communicating artery is there. Anterior limb is supplied by the anterior cerebral artery. কোন ব্রাঞ্চ? মিডিয়াল স্ট্রাইড ব্রাঞ্চ। তার কোর্সটা আবার রিকারেন্ট হয়ে যায়, তাকে বলা হয় রিকারেন্ট আর্টারি অফ হিবনার। ইট ইজ দ্য মোস্ট ইম্পর্টেন্ট আর্টারি অফ দিস অ্যান্টিরিয়ার লিম্ব অফ দ্য ইন্টারনাল ক্যাপসুল। এছাড়া স্ট্রাইড ব্রাঞ্চ অফ মিডিয়া দিতে পারে, স্ট্রাইড ব্রাঞ্চ। এই হিবনার যদি হয়, এনি অক্লুশনস অর থ্রম্বোসিস অর হেমারেজ, তাহলে অ্যান্টিরিয়ার লিম্ব চলে যাবে। তাহলে অ্যান্টিরিয়ার থ্যালামিক রেডিয়েশন যেগুলো যাচ্ছে, এই যে অ্যান্টিরিয়ার থ্যালামিক রেডিয়েশনস, ফ্রন্টাল কর্টেক্স, এটা ড্যামেজ হবে। আরেকটা ইম্পর্টেন্ট যেটা আমাদেরকে বলতে হবে, দ্যাট ইজ চারকোট আর্টারি। কি কেন? It is the important lateral stride branch of the middle cerebral artery. This is called Charcot artery. এই জন্য বলা হয় একে artery of hemorrhage. It is a most commonly ruptured, যা কিছু hemorrhage যদি hemiplegia নিয়ে আসে, most of the common case of hemiplegia, this ruptures of this Charcot arteries that is supplying the posterior limb. ফলে posterior limb যদি হয়, if the posterior limb is affected, তাহলে pyramidal fibers, extrapyramidal fibers along with the corticonuclear fibers are affected. So there is a contralateral hemiplegia, very most common hemiplegia, rupture of the Charcot artery. And Charcot artery is a lateral stride branch of middle cerebral artery. এটা মনে রাখতে হবে। কেন বারবার রাপচার হয়? এটা always remains in under constant high pressure of the cerebrum. Number 2, no collateral vessels is there. ফলে একবার রাপচার হলে হেমারেজ হবেই হবে। কোনো collateral circulation is not there and very vulnerable, যে কোনো সময় রাপচার হতে পারে। আমাদের তো কম বয়সে তো হবে না, যারা হাই প্রেশার, প্রচুর স্ট্রেস অ্যান্ড টেনশন, ইন্টারক্রেনিয়াল টেনশন বেড়ে আছে, সেক্ষেত্রে হতে পারে। চারকোট, এটাই ক্লিনিক্যাল ইম্পর্টেন্স, আরো অনেক আছে, এটা এইটুকু জানলেই হবে। ইন্টারনাল ক্যাপসুলস কটা বাজলো? Thank you everybody, and also thanks to this lady who has come to the lecture class with fever. এটাও তো ভালো জিনিস, ফিভার নিয়ে কি আছে রে, ফিভার নিয়ে তো হোস্টেলে থাকবে। অতএব ইন্টারনাল ক্যাপসুল ইজ very important, not for theoretical exam, for your future. If you know the internal capsule, you will be a good clinician. And most of the, in modern days, the hemiplegia, stroke is very common to everybody. So if you know the exact, so the next class will এসে গেছে, তাহলে হতে thank you everybody, তারপরে পরে আবার দেখা হবে।
Okay, so good morning students. So I guess you have only 2 months remaining for your professional examinations, and from right now onwards you need to focus definitely on your study, and remember the way of studying right now should be somewhat different. So you need to move on to different topics. Say for example, every half an hour. Okay, and that should be changing topic or switching to a different topic or maybe switching to a different subject. It should be your way of entertainment, not taking your mobile out and invest some time in Insta or FB or maybe going to Bolpur market, right? So every 15 minutes or every 30 minutes switch to a different topic, and this switching should be your entertainment, right? So there is no question of any boredom, just switch to a different topic and overcome this boredom, right? Okay. So for every subject, syllabus is almost complete, and for physiology as well, I guess your syllabus is almost complete. Only 5 to 6 topics are remaining, but I will consider that your syllabus is complete. So now onwards, you switch to different topic every time. Okay, it should not be like the way you are studying a same topic or a same chapter, right? So every time you switch system. So say for example, you are studying respiratory system and you are getting bored, immediately switch to a different topic or maybe different subjects, right? So in this way, you start your study. So that is the best way right now. 2 months remaining, right? So today I will discuss a few hot areas from different systems. So sort of scatters. So few important areas I will cover, and I will try to cover or I will try to take more such scatters topic. Okay. So first topic is descending analgesia system. Okay. So first question. So I'll move on to different systems, right? So descending analgesia system is under your nervous system. So right now your target should not be your semester exam. Your target should be your professional exam, right? So target all the topics and throughout your book, right? So descending analgesia system, first CNS topic, nervous system topic, descending analgesia system. So what is your pain pathway? The most common pain pathway is spinothalamic tract. Very good, spinothalamic tract. So descending analgesia system, it is an inbuilt system which is present in your nervous system, which tries to reduce your pain sensation. Okay, and under descending analgesia system, we have the periaqueductal gray and your raphe nuclei. Okay, one is inside your midbrain and another is in the medulla. Okay, so these are the areas which contains opioidergic neurons, and this is the mechanism of opioids like morphine, pethidine, right? So these are mostly the pharmaceutical agents which are used to reduce pain sensation, say for example during cancer chemotherapy or in a cancer patient, right? So for severe patient we use opioids. So how does opioid act? Okay, by answer is by acting through descending analgesia system, right? So just if this question comes, descending analgesia system, as a short note, just drawing this diagram and writing few lines will be more than enough, right? So this is descending analgesia system. So we have these green colored opioidergic neurons. So these two neurons, these two green colored neurons are opioidergic neuron. This one is the spinothalamic tract, the pain sensation coming through the first order neuron, and as you know, it is immediately crossing to the opposite side and ascends as spinothalamic tract, right? Ascends as lateral spinothalamic tract, goes to thalamus, and via thalamus goes to cerebral cortex, right? Now this is the normal pain pathway, right? And this is the descending analgesia system, right? This is the descending analgesia system, and these green color neurons are opioidergic neurons. Okay, so they release opioids, but normally this opioidergic input to the descending analgesia system is inhibited by those interneurons. So you see these red color neurons, small interneurons, they are inhibitory neurons, right? So stimulation of the descending neurons in the periaqueductal gray and raphe nuclei produces analgesia, right? And this is under descending analgesia system. Okay. Under normal condition, these neurons are tonically inhibited by those red color short interneurons under normal condition. So under normal condition, your this descending analgesia system is almost not working because of working of those short red colored inhibitory interneurons. Now opioidergic neurons inhibits those inhibitory interneurons so that periaqueductal gray and raphe nuclei neurons can inhibit the second order 10 sensory neurons in the dorsal root of the spinal cord uninterrupted. Now you give the patient opioids, patient opioids so that those opioidergic neurons inhibit those interneurons. Now the descending analgesia system will be working, right? So what happens? You give opioid or morphine, pethidine to the patient. So these inhibitory interneurons are working, right? Initially under normal condition, these inhibitory interneurons are working so that this analgesia system is not working. Okay. Now when you are giving or injecting opioids, morphine or pethidine to the patient, this green color neurons, they will inhibit those interneurons. Now the descending analgesia system will be working and it will work on the second order neuron of the spinothalamic tract to reduce pain sensation, right? So just draw the diagram and label what are the interneurons, what are their roles and what are those opioidergic neurons. Okay. And very important question in Viva as well, your examiner will ask you what are the areas where these opioidergic neurons are found. Okay. Answer is periaqueductal gray in the midbrain and raphe nuclei medulla, at the level of medulla, right? Okay. Switching for our entertainment. So respiratory system. Respiratory system, the question is oxygen debt or oxygen debt mechanism. Okay. Question is oxygen debt or oxygen debt mechanism. So what is oxygen debt? So this is the definition. The magnitude of oxygen debt is the amount by which oxygen consumption exceeds basal consumption from the end of exertion until oxygen consumption has returned to the pre-existing basal level. Okay. How much is the basal oxygen consumption? How much oxygen you are consuming when you are almost resting? 250 ml per minute. Yes, 2 to 3 ml per. 250 ml per minute. So I am resting, I am completely resting, say for example lying on a bed or on a couch, right? So my oxygen consumption is 250 ml per minute. Prati minute 250 ml oxygen khachi. Now I am exercising. Okay. Now I am exercising, increasing the grade of exercise, 250 ml per minute, now 600 ml per minute, again exercising, increasing the grade, 1000 ml per minute, 1.5 liter per minute, 2 liter per minute, 3 liter per minute, 3.5 liter per minute. 3.5 liter is my maximum. What is this called? VO2 max. VO2 max is my maximum oxygen consumption, and you know VO2 max is your performance indicator. Okay. VO2 max is your performance indicator. On an average individual with a sedentary lifestyle, 3.5 liter per minute is the VO2 max. In a 60 to 70 kg healthy individual, 3.5 liter to 4 liter will be the VO2 max. Okay. One athlete performs or practices to increase the level of VO2 max. Okay. So in a very much trained athlete, say for example Bolt or someone like that, okay, VO2 max will be as much as 6 to 7 liter or maybe 10 liter per minute. Okay, so VO2 max, you exercise because you want to increase your VO2 max. VO2 max is your performance indicator, right? Okay. So now we have 3 different energy systems in our body. What are those? One is phosphagen system or phosphocreatine system. Okay, phosphocreatine system is the first energy system which you consume. Okay, second, yes, anaerobic, anaerobic and aerobic. Okay, phosphagen system or phosphocreatine system, anaerobic and aerobic. Okay, so it depends on your mood of exercise, which system to deploy first. Okay, so say for example, a ghost is on your behind, okay, chasing you. So you will apply which system? Phosphagen system. You will apply phosphagen system. Okay, so you are about to miss the train. Okay, you are about to miss the train and you are running. You will apply phosphagen system. Okay, and say for example you have marathon race. So slowly you will just so you will apply your aerobic system. Okay, so it depends on the type of exercise you will perform. Okay, so it is first the phosphagen system, second anaerobic system, and lastly your aerobic system. The difference is aerobic system gives you very slow output. Okay, you cannot perform a heavy task with phosphagen system. So say for example an weightlifter. Okay, so a weightlifter when lifts 200 kg or 250 kgs of weight, so he or she will apply phosphagen system. Okay, but to carry on some continuous endurance activity, we need ATP system or aerobic system. Okay, now in a healthy individual, after 4 minutes of strenuous exercise, all those systems are finished, and only aerobic system will continue to supply you energy at a very slow rate. So phosphagen system gone. Okay, then anaerobic system, lactic acid production, then finally aerobic system at a very slow rate ATP will be produced. Okay, your phosphagen system gives you high amount of ATP within a very short period of time. That is required during strength training, weightlifting. Okay, and during marathon you require your aerobic system. So that is why marathon runners, they load themselves with carbohydrate and performs. Okay, so after 4 minutes of severe exercise or strenuous exercise, all these systems are exhausted. Only your aerobic system is working with very little amount of ATP, 1 ATP. Okay, sorry. Okay, so after 4 minutes, this is your basal oxygen consumption, which is 250 ml per minute. So this 4 minutes of exercise and your VO2 max is now 3.5 liter per minute, right? 250 ml per minute is the baseline, your basal oxygen consumption, and after 4 minutes of strenuous exercise or heavy exercise, your VO2 max is 3.5 liter. So every minute you are consuming 3.5 liter of oxygen per minute, right? Now from this point, gradually you will come to the basal level. Okay, now the extra oxygen you are consuming to come to this baseline is the oxygen debt, right? It is the oxygen debt. So on in a healthy individual, it is total 11 liter, 3 liter plus 8 liter. So 3 liter is the 2 liters of stored oxygen in the myoglobin plus 1 liter to replenish your phosphagen system. So this is called alactic compensation. Okay, alactic compensation, and the remaining 8 liter, it is for the removal of lactic acid. So this is total 11 liter of oxygen debt. After reaching to VO2 max, you come to baseline. After reaching to VO2 max and after performing severe exercise for 4 minutes, you are at the VO2 max, and from VO2 max you come to baseline, that is 250 ml per minute oxygen consumption. Okay, so from this point to this point, total 11 liters of oxygen you are consuming. So how this 11 liter of oxygen is distributed? 3 liters of oxygen is required to replenish the stored oxygen with the myoglobin, and 1 liter of oxygen is required to replenish the phosphagen system or phosphocreatine system, and remaining 8 liter or most of the oxygen is required for removal of lactic acid from your blood, right, for removal of lactic acid. So, this total duration it almost requires 50 minutes, 50 minutes and may extend up to 90 minutes, right. Okay. So, this is time after exercise. So, clear oxygen date. So, if this question comes oxygen date, you need to define oxygen date and you need to explain this part. That is it. Okay. No extra talking, only writing, only drawing this diagram and definition of oxygen date, and you may explain, if you get time, you may explain how this 3 liter and 8 liter is distributed, right. But you can write everything on the diagram like this. Okay. So, that makes your answer complete. This is the definition of oxygen date. Again, moving to nervous system. Switching topic, moving to nervous system. So, what is the role of melatonin in sleep cycle? What is the role of, these are very hot topics I have picked for today. What is the role of melatonin in sleep cycle? So, again if you draw one diagram, that will make your answer almost complete, not almost complete. Okay. So, light falls on the retina. Okay. Better you start from here. SCN is suprachiasmatic nucleus. SCN is suprachiasmatic nucleus, right. So, SCN has got a connection. SCN is suprachiasmatic nucleus. It is located within thalamus, hypothalamus. Okay, suprachiasmatic nucleus is located within the hypothalamus. It is a hypothalamic nuclei. Suprachiasmatic nucleus is a hypothalamic nuclei. Okay, and it induces your sleep. It induces your sleep, right? So, you are seeing that suprachiasmatic nucleus is getting input. Suprachiasmatic nucleus is getting input from two areas. One is from your retina through retinohypothalamic tract. Okay, one is from your retina through retinohypothalamic tract, and another is from your pineal gland. Okay, retinohypothalamic tract is inhibitory to suprachiasmatic nucleus. Okay, so it is retinohypothalamic tract is inhibitory. That is why it is red. Okay, so retinohypothalamic in your diagram you can put dotted lines for inhibitory action and solid line for stimulatory action. Okay. So, from retina you have retinohypothalamic tract which is converging on the suprachiasmatic nucleus, and now suprachiasmatic nucleus also receives an input from pineal gland, and these neurons will secrete melatonin. Okay, these neurons will secrete melatonin. Melatonin has got two receptors. One is the MT1 receptor and MT2 receptor. Both are G protein coupled receptor, but the major action is by MT1, which is again a G protein coupled receptor. Okay. So normally what happens? How suprachiasmatic nucleus induces sleep, or how melatonin induces sleep? So suprachiasmatic nucleus, it converts into intermediolateral nuclei of the spinal cord. Okay, IML is in the spinal cord. Intermediolateral nuclei of spinal cord, and from this spinal cord, the preganglionic neurons goes to superior cervical ganglion. Superior cervical ganglion. Okay, superior cervical ganglion, and from the superior, it is a sympathetic ganglia. So from superior cervical ganglia, postganglionic neurons will secrete what? Norepinephrine. Postganglionic neurons will secrete norepinephrine, and this postganglionic neuron will work on the pineal gland, which is located in the roof of the third ventricle. Now, pineal gland will secrete melatonin, and MT1 receptors through MT1 receptors, melatonin will act on suprachiasmatic nucleus to induce sleep. Okay. So this is the stimulatory action on suprachiasmatic nucleus to induce sleep, right? But when light falls on retina, this retinohypothalamic tract is activated, and it is trying to inhibiting suprachiasmatic nucleus and during sleep, right? So that is why we need a darkness during sleep, right? Okay, so how does it happen? So MT1 receptors in the suprachiasmatic nucleus, it is a G protein coupled receptor which is coupled to inhibitory G protein or GI, and when stimulated it reduces cyclic AMP because it is inhibitory G protein, right? So it will reduce the amount of cyclic GMP formation in the suprachiasmatic nucleus and this will cause sleep, right? Postganglionic neurons from the superior cervical ganglion, I mentioned, it will release norepinephrine, which acts on the beta adrenergic receptor, increase cyclic AMP, stimulate one enzyme N-methyl transferase, and increase synthesis of melatonin, right? So you need to remember the synthesis pathway of melatonin as well. Very important picture. This is directly taken from Ganong. So serotonin, from serotonin, how melatonin is formed. This is the pathway, and you see the concentration of melatonin is high. This shaded area is nighttime. Shaded area is nighttime, and the light area is during daytime. So you see that melatonin concentration is high during night, and serotonin concentration just reverse during nighttime. Concentration is low, right? So this is how melatonin induces your sleep, and this is the enzyme which converts serotonin towards melatonin N-acetyl transferase, and this enzyme activity is increased by norepinephrine. Clear? So again, a very simple question. Just remember this diagram and this diagram. I'll give you full marks. Anyone will give you full marks. Okay. So if you draw this diagram and if you write this, you will get full marks. Nothing to write. Everything is given in the diagram, right? So this is the role of melatonin for inducing sleep. Okay. Switching topics. So respiratory failure. So before respiratory failure, you need to know something. So you need to know two very important things whenever you will be dealing with the patient of respiratory failure. So respiratory failure might be the final outcome of different respiratory diseases, right? So different respiratory diseases might ultimately lead to respiratory failure, maybe bronchial asthma, maybe COPD, maybe acute respiratory distress syndrome. So all those diseases, or emphysema, all those diseases might ultimately lead to respiratory failure. Okay. So respiratory failure means this blood gas parameter, partial pressure of carbon dioxide in your blood or partial pressure of oxygen in your blood might be deranged, right? So this is respiratory failure. Your lung is not able to maintain the proper partial pressure of carbon dioxide and oxygen in your blood, right? This is respiratory failure. Now, we have two different terminologies here. One is intrapulmonary shunt and dead space ventilation. Intrapulmonary shunt and dead space ventilation. So first, let me show you this picture. So dead space ventilation, what is dead space ventilation and what is intrapulmonary shunt? So this is just diagrammatic. So say for example, this yellow one is your alveoli, and this is the blood vessel which is perfusing that alveoli. Now say for example, there is a block here, okay, so there is a block here and this is the direction of blood flow, this is the alveoli, and the diffusion should happen here at the alveoli blood vessel barrier, right? This is the alveoli blood vessel barrier, and through this barrier diffusion should happen, right? Now say for example, there is a block here in the blood vessel, right? There is a block here in the blood vessel, so your air is entering into the alveoli and moving back, but as there is a block, so no blood should be here, right? So this ventilation is wasted, right? So this ventilation is wasted. Air is entering and exiting, but not diffusing, okay? So there is no question of diffusion here. So it is dead space ventilation, okay? So it is dead space ventilation. What will happen to blood gas parameter? Can you have any idea? What will be your blood gas parameter in case of dead space ventilation? What should be the partial pressure of oxygen and what should be the partial pressure of carbon dioxide? Okay, I am coming to it. Now the next is ventilation is not happening. So here, what is ventilation? Ventilation is the convective movement of air to and from the alveoli. Ventilation is defined as the convective movement of air to and from the alveoli. Simply, air entry and air exit. This is ventilation. And what is perfusion? Perfusion is the convective movement of blood to and from the alveoli. Okay. So three events are happening here. One is ventilation, another is perfusion, and third is diffusion. Okay. So everything need to be in sync, right? To maintain your partial pressure of oxygen, to maintain your partial pressure of carbon dioxide, right? So here there is a block here. So perfusion is not happening. Okay. So perfusion is not happening, but the ventilation is happening. Okay. So this is dead space ventilation. Okay, so ventilation is wasted, right? Now here ventilation is not happening. Okay, here ventilation is happening, perfusion is happening. So the blood is coming here and it is exiting without getting any oxygen, right? So this is intrapulmonary shunt. So two deviation from physiology might be there. One is dead space ventilation and another is intrapulmonary shunt, right? So clear? Now imagine in your mind, one pathology will be characterized by hypoxemia only, and another pathology will be characterized by both hypoxemia and hypercapnia. Now you imagine what dead space ventilation will be characterized by hypoxia or hypoxemia, or intrapulmonary shunt will be characterized by hypoxia or hypoxemia. One event is characterized by hypoxia only, and another event is characterized by both hypoxia and hypercapnia, right? Just imagine. Okay. So respiratory failure, we divide respiratory failure into two. Okay. So one is hypoventilation and another is ventilation perfusion mismatch. Okay. Ventilation perfusion mismatch. Both intrapulmonary shunt and dead space ventilation. Previous two examples. Okay. Both intrapulmonary shunt and dead space ventilation are the examples of VQ mismatch. Okay. So I told your ventilation, your perfusion, your diffusion, everything need to be in sync, and whenever this synchronization is lost, there will be ventilation perfusion mismatch. Okay. Now ventilation perfusion mismatch, it will be either dead space ventilation or intrapulmonary shunt. Okay. Whenever there is, I am discussing this first. So ventilation perfusion mismatch, it will be either due to dead space ventilation or it might be due to intrapulmonary shunt. So examples of dead space ventilation, destruction of the alveolar capillary interface as in emphysema and advanced stages of any lung disease, like COPD or bronchial asthma, right? ARDS. So dead space ventilation will be characterized by both hypercapnia, high PaCO2, and hypoxemia, low PaO2, right? So dead space ventilation will be characterized by both hypercapnia and hypoxemia, and intrapulmonary shunt is characterized by normal partial pressure of carbon dioxide and low PaO2, that is hypoxemia. Okay, so intrapulmonary shunt is characterized by only hypoxemia. Okay, carbon dioxide partial pressure will be absolutely normal. Okay, now with your idea, can you tell me COVID pneumonia is dead space ventilation or intrapulmonary shunt? What? Intrapulmonary shunt, because it is characterized by only hypoxemia. Okay, it is characterized by only hypoxemia. All the COVID patients, those who were being admitted in the ICUs, they were presenting with hypoxemia. Okay, and reduced saturation, but their partial pressure of carbon dioxide was absolutely normal. Okay. So COVID pneumonia again, it is simply ARDS. It is written here, ARDS, acute respiratory distress syndrome, which was the outcome of COVID pneumonia. Now it's not happening. Okay. So acute respiratory distress syndrome, it is an example of intrapulmonary shunt. Okay. So respiratory failure, one is VQ mismatch and another side is VQ normal. Okay. So VQ mismatch and VQ normal. So simply dead space ventilation is happening, but perfusion is not. So V by Q more than 1. Okay. Simply see this picture. So ventilation is happening, but no perfusion. So V by Q more than 1, right? And here what is happening? Ventilation is not happening, but perfusion is happening. Okay? So less than 1. Okay. Now respiratory, another arm of respiratory failure is hypoventilation. Okay, now hypoventilation might be due to different causes. How to differentiate between hypoventilation and ventilation perfusion mismatch or VQ mismatch? Simply by performing alveolar arterial oxygen gradient. Okay, capital A minus small a. Okay, alveolar minus arterial oxygen gradient. In case of hypoventilation, it will be absolutely normal, and in case of VQ mismatch, the gradient will be high, right? So hypoventilation again might be due to central and peripheral. Central, for example, narcotic drugs. Okay, central, for example, narcotic drugs, and peripheral due to neuromuscular blockers. Again, we can differentiate between central and peripheral by maximum inspiratory effort. No need to remember. Okay. So respiratory failure, you can just show this classification and give some examples, right? But what is most important is your concept on intrapulmonary shunt and dead space ventilation. Okay, and make an idea why there will be both hypoxemia and hypercapnia in case of dead space ventilation, and why there will be only hypoxemia in case of intrapulmonary shunt. Okay, switch. Okay, very important question from endocrinology or reproductive physiology. Functional aspects of testosterone and dihydrotestosterone. Okay, so simply remember, nothing to understand here. Simply remember what are the functions of testosterone and what are the functions of dihydrotestosterone. I guess you already know how dihydrotestosterone is formed from testosterone. The enzyme is 5-alpha reductase, right? The enzyme is 5-alpha reductase, testosterone to dihydrotestosterone. Now, in male physics, this testosterone and dihydrotestosterone, these two hormones have different actions. Okay, different actions. So see their actions. Testosterone functions are Wolffian duct maturation, bone growth, muscle growth, male type of brain, erythropoiesis, spermatogenesis. Now some metabolic effects like increasing your VLDL, LDL, but reduction is HDL, right? This is bad only. And adipose tissue deposition in the abdomen. So all these are functions of testosterone. Okay. Now how it differs with the functions from dihydrotestosterone? See, dihydrotestosterone formed by 5-alpha reductase. It is of two types. Type 1, it is formed in the sebaceous gland during puberty, and type 2 in male urogenital organs, skin and liver. Okay. So what are the actions of dihydrotestosterone? Growth of prostate, bulbourethral gland, development of external genitalia, penis scrotum from the common developmental analgen, temporal recession of hair, male pattern, right? Male voice, beard, mustache, right? Sebaceous gland activity, all these are due to dihydrotestosterone. Okay. Simply in viva, your examiner may ask you erythropoiesis. Is it the action of testosterone or dihydrotestosterone? Okay, so examiner will try to confuse you, right? So remember actions of testosterone and dihydrotestosterone. I repeatedly tell you that nothing to remember in physiology, but here in endocrinology and reproductive system, there are so much to remember, right? So simply remember, there is no way out. What are the functions of testosterone and what are the functions of dihydrotestosterone? Switch. Okay, bone turnover, again very important question. Bone destruction and bone formation, new bone formation and bone destruction. So in our human body, these two events are in balance. That is why you are not losing your bone mass, you are not having any osteoporosis, right? And also you are not having any increased bone density or osteopetrosis like that. Okay? So your bone density is fixed because your bone turnover is in balance, right? Bone destruction is equal to bone formation. So we must keep it in balance. Otherwise there will be diseases like osteoporosis, increased bone destruction, low bone density. Okay. So how it is happening? The physiology. physiology, you need to explain. Very important question, right? So to know this is the normal anatomy of bone. You have studied already in histology, might be in anatomy, right? So you have the lining cells, the osteoblast, the canaliculi, osteocytes, Haversian canal in the center, the bone matrix and the osteoid, right? So osteoblast secretes osteoid, a proteinaceous material which contains collagen, type 1 collagen 90% and 10% proteins like osteocalcine and osteonectin, okay? And both these proteins bind to calcium in hydroxyapatite crystal. You may remember the formula of hydroxyapatite crystal, Ca10, PO46 and OH2, right? So this is the anatomy in a nutshell. Okay. Now see this, right? So this is your osteoclast or mature osteoclast, and this one is your osteoblast, and we have two hormones acting over here. One is vitamin D and another is parathormone. Okay. One, just simply drawing this and writing few lines, enough. Okay. So you see, this is the osteoblast, right? This is the osteoblast, and this osteoblast is affected by two important hormones. One is parathormone, and I told vitamin D we consider as a hormone. So vitamin D and parathormone, okay, stimulating the osteoblast. Now osteoblast will secrete, osteoblast under the influence of vitamin D and parathormone, it will secrete four substances. One is interleukin 6, another is MCSF, another is rankle or rank ligand, and another is osteoprotegerine or OPG. Okay. So four substances are secreted by osteoblast. Please remember MCSF, interleukin 6, rankle and OPG, right? Now what are their diverse functions? Okay. So see the diagram. So this is MCSF being secreted from osteoblast. Now MCSF is stimulating the stem cells to convert into osteoclast precursors. This is the action of MCSF. Okay. Now interleukin 6, it binds to interleukin 6 receptor, IL-6 receptor, which is located on the cell surface of osteoclast precursor. And again, osteoblast is also secreting two important substances. One is rankle and another is osteoprotegerine or OPG. Okay, OPG and rankle, both are having opposite actions. Okay, they are having opposite action, but they are being secreted by the same cell, osteoblast, with the influence of vitamin D and parathormone, right? Okay. Now rankle will again bind to rank, okay, which is again a receptor on the cell surface of osteoclast precursors. Okay, and it will convert binding of interleukin 6, binding of interleukin 6 to interleukin 6 receptor, and binding of rankle to rank. It will convert osteoclast precursor to mononuclear osteoclast or pre-osteoclast, right? So it is just both rankle and interleukin 6. Both rankle and interleukin 6, they are helping in maturating osteoclast to osteoclast precursor to mononuclear osteoclast, right? Now what is the function of OPG? OPG is just scavenging. OPG is just scavenging rankle. Okay. OPG is combining with rankle so that rankle cannot bind to rank receptor. Right? Okay. Now once osteoclast is mature, it will do what? Bone resorption, bone destruction, and you have the specific mechanism, the HCl and all those things. Right? So once osteoclast is matured, it will cause bone resorption. So both interleukin 6 and rank both interleukin 6 and rankle, they are helping in bone resorption or bone destruction, right? But the action of OPG is, as it is scavenging rankle, so it is preventing bone resorption. Okay, so OPG is preventing bone resorption, good only. It is preventing bone resorption, and rankle interleukin 6, they are doing or they are helping in bone resorption, right? Okay. Now pathogenesis of osteoporosis. Pathogenesis of osteoporosis comes here. How osteoporosis occurs. Okay, very commonly in post-menopausal women. Okay, in post-menopausal women, what happens? Actually, it is the balance. It is the balance between rankle and OPG. Okay, it is the balance between rankle and OPG which determines whether newborn formation will be high or bone resorption will be high. Okay, so there is a perfect balance between rankle and OPG which maintains your bone density. And once this ratio is hampered, your bone density hampered, right? And this is the pathogenesis of osteoporosis. Okay, estrogen deficiency in postmenopausal women causes the shift of this ratio towards rankle, matlab more rankle than OPG. So what will happen? Bone resorption. Okay, more rankle than OPG, that means bone resorption. And how does that happen? Due to estrogen deficiency, due to glucocorticoid therapy. Okay, whenever you are treating a patient with glucocorticoid, there will be osteoporosis for long term. If you are using glucocorticoid to treat a patient for a long term basis, there will be osteoporosis. And also in postmenopausal women, due to deficiency of estrogen, that is why hormone replacement therapy is given, right? That is why hormone replacement therapy is given during postmenopausal period, right? Okay, now see the text. Vitamin D and parathormone stimulates osteoblasts to secrete 4 substances. One is GM-CSF, interleukin 6, rankle and OPG. MCSF act on the stem cell to form osteoclast progenitor cell. Both interleukin 6 and rankle acts on the osteoclast progenitor cell to transform into mononuclear osteoclast. Just I told, rankle receptor rank is a TNF receptor superfamily. Both interleukin 6 receptor and rank are receptor tyrosine kinase associated. Okay, receptor tyrosine kinase associated. That means what? Growth hormone, JAK-STAT pathway. Okay, so receptor tyrosine kinase associated, present on the cell surface of osteoclast progenitor cell. Now OPG binds to rankle and thus prevent osteoclastic effect. Osteoporosis is due to high rankle by OPG ratio. Okay, osteoporosis is due to high rankle by OPG ratio. Estrogen deficiency and glucocorticoid can shift the balance towards rankle, right? Lastly, denosumab, it is a monoclonal antibody which is used as a treatment of osteoporosis. It is a human recombinant antibody which destroys rankle, right? It is a monoclonal antibody against rankle. So it destroys rankle, right? Very costly drug, not used very much. Okay. Moving to renal excretory system, glomerulotubular balance. Any idea? What is glomerulotubular balance? Very important short note. Glomerulotubular balance, not tubuloglomerular feedback. Okay. TGF is different. It is GTB. Okay. Glomerulotubular balance. Glomerulotubular balance or GTB. What is that? Okay. Okay, pardon for this bad drawing. Anyway, so your proximal convoluted tubule is ultrastructurally divided into S1, S2 and S3. Your proximal convoluted tubule is divided into S1, S2 and S3. Matlab segment 1, segment 2 and segment 3. Okay. So this is proximal convoluted tubule S1, S2, S3. Okay. Now S1 segment is intraluminal negative. S1 segment is intraluminal negative and S3 segment is intraluminal positive. How? Because in the S1 and S2 segment, most of the anionic substances, your amino acids, okay, most of the amino acids which are bearing negative charge, all these things are absorbed in your S1 segment. Okay. So S1 segment is largely negative. S1 segment is largely negative because of the presence of anions. Now all these mostly amino acids. Now all these amino acids will be absorbed in S1 and S2 segments, and all the cations, magnesium, calcium, will remain inside S3. Okay. So your S3 is positive, intraluminal positivity. So please remember this. In the proximal convoluted tubule, we have S1 to S3 segment. S1 is intraluminal negative and S3 is intraluminal positive due to deficiency of anions. Okay. So this is again one way of calcium reabsorption through paracellular pathway. One example of calcium. Calcium is reabsorbed through transcellular pathway as well as paracellular pathway. In transcellular pathway, we have the TRPV5, TRPV6, right? And in paracellular pathway, what is paracellular pathway? That means this is your lumen and this is the luminal cells. So this is paracellular path. So this is paracellular path. As this is S3, so as the luminal positivity is there inside, so calcium ion will be repelled, right? Calcium ions will be repelled from inside the lumen towards the bloodstream. So this is how calcium is reabsorbed through paracellular pathway in S3 segment. Remember, calcium is not reabsorbed in S1 segment. Calcium is reabsorbed in the S3 segment due to repulsion, right? Because calcium is a positive ion, and in S3 there is intraluminal positivity. So that is why calcium is reabsorbed through paracellular pathway in the S3 segment. Clear? Okay, anyway, I'm coming to it. Glomerulotubular balance or GTB. So here, what is GTB? So simply the definition is, it is a phenomenon that keeps a constant fraction of sodium and water reabsorption from the proximal convoluted tubule despite changes in GFR. Okay. Despite changes in GFR, constant fraction of sodium is reabsorbed in the proximal convoluted tubule. So this is called glomerulotubular balance. So say for example, GFR is increased. Okay, so we start with this point. GFR is increased. That means this is the lumen. Okay, this is the lumen. This is luminal cell, and this one is the lumen, right? And this is the bloodstream and peritubular capillary. Okay, so here. So if I draw here, afferent, efferent, okay, and this is peritubular capillary. This is peritubular capillary, okay, peritubular capillary. Now once GFR is increased, so GFR is increased, matlab more sodium is being filtered coming to proximal convoluted tubule and less sodium is coming to peritubular capillary. Clear? So once GFR is increased, more sodium is coming into the tubular lumen, proximal convoluted tubule, and less sodium is moving through efferent arteriole into peritubular capillary. Correct? Okay. So now GFR is increased, more sodium is moving inside the lumen, and less sodium is coming to peritubular capillary. Right? Okay. So now the sodium here is absorbed through SGLT2. In kidney, SGLT2. In GI tract, SGLT1. Okay. Two kidneys, that is why SGLT2. Remember in this way. Okay. So SGLT2, glucose and sodium co-transport, sodium moving inside. Now at the basolateral membrane, there is sodium potassium ATPase. Now sodium is here, between the luminal cell and the peritubular capillary. Now this sodium can have two fates. One, this sodium can backleak again into the lumen, and second, this sodium can go through filtration inside the peritubular capillary. Right? Now what will happen? As GFR is increased, So more sodium is here in the peritubular lumen and less sodium is here in the peritubular capillary, right? So peritubular capillary, less sodium means less hydrostatic pressure, okay? Less sodium means less hydrostatic pressure, right? Less hydrostatic pressure. Now sodium will move here, okay? Because the pressure over hydrostatic pressure over here will be more than the hydrostatic pressure here. So there will be more filtration. Okay. Now think of the opposite thing. GFR is decreased. Okay. So GFR is decreased. Now less sodium is here, less sodium will be coming here, less sodium will be absorbed. Now less sodium will be here. But more sodium will be going through efferent arteriole into the peritubular capillary. So the hydrostatic pressure inside the peritubular capillary will be high. Hydrostatic pressure inside the peritubular capillary will high. So more sodium will move in this direction backleak into the lumen, right? So irrespective of the changes of GFR, same fraction of sodium will be absorbed from the peritubular, from the proximal convoluted tubule. This is called glomerulotubular balance, GTB, right? Again a very important short note for you. Should I switch or okay? Action of aldosterone at the cellular level. So simply tell me one single line. What is the action of aldosterone? What is the action of aldosterone? You, Ritik? Sodium and water reabsorption from कहाँ से? DCT and collecting tubule. So action of aldosterone is reabsorption of sodium and water from distal convoluted tubule and collecting duct. Okay, distal convoluted tubule and collecting duct. So what is happening at the level of collecting duct? This is epithelium sodium channel, ENSC, everyone knows. Okay, epithelial sodium channel, sodium enters into the cell, right? And at the same border or apical border, we have the ROMK channel. What is ROMK? Renal outer medullary potassium channel. Renal outer medullary potassium channel. Okay, ROMK channel. So it is also called the leak channel or back leak channel. Okay, so sodium enters and potassium exits. Okay, and to balance this, we have at the basolateral membrane sodium potassium ATPase. Right. So this is happening in the collecting tubule. Okay, this is happening in the collecting tubule. Now, what is the function of aldosterone? Aldosterone is a what kind of hormone? Steroid, simply steroid. How does steroid act? Nuclear receptor, very good, nuclear receptor. So, steroid hormone having nuclear receptor. What are the other substances which are having nuclear receptor? Other than steroid? I told you the mnemonic STDR. S steroid, T thyroid, D vitamin D, R retinoids. Okay? Only 4 examples are there for intranuclear receptor. Right? Only 4 examples. STDR. Steroid, thyroid, vitamin D, retinoids. And there is no fifth. Right? Okay. So now aldosterone, it can enter into the nucleus and it can influence the transcription factor to translate some proteins. Okay, it can enhance synthesis of some proteins. Aldosterone has the capability to enhance synthesis of some proteins. Which proteins? All these proteins, right? So aldosterone can stimulate the synthesis of ENAC. Aldosterone can stimulate the synthesis of ROMK. Aldosterone also stimulates synthesis of sodium potassium ATPase, right? So this is in collecting tubule. And what is happening in case of distal convoluted tubule? In distal convoluted tubule, we have the sodium chloride channel, okay? Sodium chloride channel or NCC channel, thiazide diuretics acts on this channel, right? So it is a co-transporter, sodium chloride simultaneously enters into the cell, right? And aldosterone also stimulates synthesis of NCC channel, right? So So this is at the cellular level the action of aldosterone. Should I switch? Okay. Middle ear function কালকে স্যার পড়িয়েছেন কিন্তু কেউ ভালো করে শোনেনি তাই তো What is the function of middle ear? Okay, just remember a single sentence. Middle ear acts as an impedance matching device. Middle ear is an impedance matching device. What is impedance? What is impedance? It is the acha, first of all so middle ear function for writing this question your first sentence should be middle ear acts as an impedance matching device. Middle ear acts as an impedance matching device. Okay, now sound energy is of two types. One is wave, one is electromagnetic wave that doesn't require any medium to transmit like light, and another is mechanical wave which needs the medium, okay, to travel from one point to another. Example is sound. So sound needs either gaseous medium or liquid medium or any medium to transmit from one point to another point, right? Now this mechanical energy, mechanical wave like sound, it needs to vibrate the molecule of the medium. So say for example air molecules, okay. So sound to travel, it needs to vibrate the air molecules, okay, and impedance is defined as the resistance against this vibration, okay. So very simply gaseous molecule will have less impedance than liquid or solid, right? So sound can travel easily through gaseous medium like air by vibrating its molecule, right? Okay. Okay, now once this is liquid medium or water and this is air, right? Now sound, once traversing from air to liquid, air to water, sound need to face this air water interface, okay. Sound need to face this air water interface, right? So say for example air molecule vibration was this, okay, air molecule vibration. Now with the same intensity, if sound tries to pass with same intensity in the water, it needs to vibrate the water molecule with same intensity, right? Okay. But impedance of water is much more, right? Impedance of water is much more. Sound cannot make the water molecule vibrate with the same range, right? Clear? So we need some device which will match the impedance. At the air water interface, there is at least 30 decibel loss of sound. Okay. What is decibel? Sound wave is a mechanical wave, okay. It causes condensation and rarefaction, right? It causes condensation and rarefaction in air, right? So we measure sound energy with the help of pressure. What is the unit of pressure? Dyne per centimeter square, Newton per meter square. These are unit of pressure, right? So it is called sound pressure level, SPL. Sound pressure level or SPL, and the unit is definitely Dyne per centimeter square, okay. For measuring SPL or sound pressure level, the unit is definitely dyne per centimeter square, but we do not measure sound SPL with dyne per centimeter square. Why? We express sound pressure level in logarithmic way, okay. So SPL is equal to 20 log 10 base, 20 log 10 base test sound pressure by reference sound, okay, reference sound, and this reference sound is at the sea level 20 degree centigrade 1000 frequency যে সাউন্ড হয় সেই যে সাউন্ডের যে ইন্টেন্সিটি হয়, সো দ্যাট সাউন্ড ইজ 0.002 dyne per centimeter square. This is the reference sound, okay, this is the reference sound, okay. So 0 decibel means it is not the absence of sound. Log 1 is equal to 0, right? Log 1 is equal to 0. So if both of these are reference sound, so 20 log 1 is equal to 0. So SPL is 0 decibel. So 0 decibel is not the absence of sound. 0 decibel is the reference sound. Clear? Very important question. Your examiner will ask you, what is 0 decibel? So 0 decibel is not the absence of sound. It is the reference sound. Okay, and reference sound means 20 degree centigrade at the sea level, 1000 frequency, right? 1000 hertz. Okay. Now middle ear acts as an impedance matching device as the air has to enter from air to endolymph, right? And at the air water interface there is perfectly 30 decibel loss of sound at the without middle ear. If we just remove middle ear from the external auditory canal, you directly connect the tympanic membrane and oval window, okay, in the inner ear. So there will be perfectly 30 decibel loss of sound. Now middle ear prevents this by impedance matching, okay. So middle ear acts as an impedance matching. How does middle ear do that? Okay. So middle ear does this by 3 ways. Okay. First of all, the tympanic membrane oval window surface area ratio is higher. Tympanic membrane is almost 60 square millimeter. कुछ book में आपका 57 दिया हुआ है, जो भी है. Remember anything? So tympanic membrane is 60 square millimeter and oval window is 3. Thus the ratio increases the sound pressure level 60 by 3 20 times. Right? This is one. Second is the lever action of the ossicular chain, where fulcrum, it is a second class lever. Fulcrum is junction of the malleus and incus. So as you know that load into load arm is equal to effort into effort arm, and we get 1.3 times magnification here, right? And finally the buckling effect of tympanic membrane, which also contribute to multiplying the sound pressure level by 2 times. Okay, now you calculate all these things, So 20 log 20 plus 20 log 1.3 plus 20 log 2, it comes to 30 decibel. So all the 30 decibel loss at the air water interface, it is recovered, right? So this is how middle ear is acting as an impedance matching device. Clear? So without middle ear, there would be a 30 decibel loss at the air endolymph interface, but middle ear prevents this by 3 ways. Okay, one is the surface area difference between the tympanic membrane and the oval window. Okay, tympanic membrane is 20 times higher, is having 20 times higher surface area than the oval window. Number 1. Number 2, the fulcrum, the second class lever action, right? And we get 1.3 times magnification from here, and the buckling effect of the tympanic membrane 2 times. Okay, now you calculate 20 log 20, 20 log 1.3 plus 20 log 2, 30 decibel. So 30 decibel loss is recovered, right? So this is how your middle ear acts as an impedance matching device. Should I switch? Okay. पढ़ाओ ना practical class से अभी. Okay, last. ठीक है? Last. Very important question. Learning in cerebellum. Moving to CNS again. Okay. Learning in cerebellum. Learning in cerebellum. How does learning happens in cerebellum? So, first time, say for example, you are riding a bicycle or you are trying to swim, right? You are trying to swim, so your cerebellum is acting, right? So, how cerebellum helps you in motor learning, right? So, this is the cerebellar connection. This is the cerebellar connection. So, the major cell is Purkinje cell here. Okay. The major cell is Purkinje cell here. Purkinje cell receives two inputs. Purkinje cell receives two inputs. One is climbing fiber and another is Mosby fiber. You are not concentrating, I guess. Okay, last. This one is last. Okay. Purkinje cells are receiving two inputs. One is climbing fiber and another is Mosby fiber. Climbing fiber unit is direct. Climbing fiber input is direct to the Purkinje cell, and Mosby fiber input is via Golgi cell and through parallel fibers, granular cell parallel fibers, right? So Purkinje cell is receiving two inputs. One is Mosby fiber input, another is climbing fiber inputs, right? This climbing fiber input, it comes from olive, right? And Mosby fiber input, it comes from all the non-olive structures, from joints, bones, from spinal cord, right? So from all the non-olive structures, your Mosby fiber inputs are coming. That means while first time you are trying to swim or you are trying to ride a bicycle, all your joints or your muscles, your tendons, proprioceptive inputs are coming to cerebellum through which fiber? Mosby fiber. Okay, through Mosby fiber. And Mosby fiber creates simple spikes. Mosby fiber creates simple spikes on the Purkinje cells, right? And climbing fiber, C for C. Remember, climbing fiber, it creates complex spikes. Climbing fiber creates complex spikes on the cerebellar Purkinje cells. Okay. So CFI is climbing fiber input. Climbing fiber input, it is coming from CFI coming from olive and MFI coming from all non-olive structures from whole body, right? CFI causes large complex spike and MFI causes simple spikes on the Purkinje cells. And remember, CFI or climbing fiber input, it comes only at the beginning of learning. Okay? So say for example driving, when you were driving at the beginning, CFI inputs were coming to Purkinje cells. Now you have already learned driving, so now no CFI, only MFI, Mosby fiber input, right? So CFI occurs at the beginning of learning and causes smoothing or ironing over MFI spikes. So ironing means wrinkles on a kapda you iron, right? So you smoothens it, right? So this is how climbing fiber input acts on Mosby fiber inputs. Mosby fiber inputs are simple spikes and climbing fiber inputs are complex spikes which creates long-term depression on the Purkinje cell, one sort of synaptic plasticity. Okay, and you know the mechanism of long-term depression and long-term potentiation by phosphorylation and dephosphorylation of synaptic proteins. So it is long-term depression. Climbing fiber input, it causes long-term depression in the Purkinje cells by dephosphorylating synaptic proteins. Okay, so I guess 10 questions we have discussed, right? So next time again we will take such scatters class, right?
Acha, good afternoon to all of you. Today's topic is free radicals or ROS. ROS full form janish? ROS? Hello? ROS mane ki? Good. And antioxidant. Acha, have you any idea about free radicals? Have you any idea about free radicals? It is the easy circle. Free radicals the easy circle. What is the definition of free radicals? এটা হচ্ছে না বলছি free radicals এর definition কি? Free radicals are molecule having unpaired electron at outer cell, তাই তো, and which exist independently, তাই তো? আচ্ছা, free radicals are molecules or molecular species that contains free radical. এই এত কথা বললে কি করে হবে? আচ্ছা, types of free radicals. As oxygen is essential for our body for various metabolic process. এই এত কথা বললে হবে না, কথা যদি বলতে হয় গো আউটসাইড, ঠিক আছে? দুটো কাজ তো একসঙ্গে হয় না, হয় তুমি কথা বলো বাইরে গিয়ে, আর চুপচাপ বসে থাকো। আচ্ছা, ডিউরিং দ্য মেটাবলিক প্রসেস oxygen is completely reduced. If the oxygen reduction is incomplete, then the free radicals in the body is produced. There are various types of free radicals in our body. এই এত কথা বললে কিন্তু হবে না, হ্যাঁ, ঘুরে ঘুরে পড়ানো সম্ভব নয়, ঠিক আছে? Main free radicals of our body is hydroxyl ion, superoxide, those are the mechanism of production of free radicals. Main free radicals of our body is superoxide, O2, O2 ion, then hydrogen peroxide. Hydrogen peroxide is a molecule, but it is very reactive molecule. Then it is called, that's why it is called free radicals. It is under the group of free radicals. Another is hydroxyl ion, OH. Besides this superoxide, hydroxyl ion and hydrogen peroxide, there are many other free radicals in our body, such as singlet oxygen, hydroperoxy radical, lipid peroxide radical, and nitric oxide. As characteristics of free radicals are very reactive, half-life, very short half-life, only few seconds. They can produce free radicals by chain reaction. Okay. Another characteristics of free radicals are they can damage to the biomolecules, cells, and tissues. Where from the reactive oxygen groups, reactive oxygen species are produced. You have all know that for our metabolic purpose, oxygen is very essential. This oxygen, when the oxygen is reduced completely, then the procedure is normal or oxygen is produced. Water is produced. If the reduction of oxygen is incomplete, then the free radical molecules are produced. There are two processes or source of production of free radicals. First one is biological process or cellular metabolism. Second, due to environmental effects. As the first one, biological process or cellular metabolism, by which we can get the free radicals are leakage of, you have known about, you have read about the electron transport, yes or no? Electron transport system. Achha, leakage of electron transport, electrons from respiratory chain. Second, production of hydrogen peroxide and oxygen by oxidase enzymes. Second, third, paroxysmal generation of oxygen and hydrogen peroxide. Nitric oxide generation from arginine during the course of phagocytosis. Free radicals are also produced. Lipid peroxidation is another process by which free radicals are produced. Achha, next I am coming to environmental process by which free radicals are produced. During the metabolism of drug, free radicals are produced. By the photolysis of oxygen, the free radicals are produced. Another is photoexcitation of free radicals. Smoking. Smoking is a part of our daily life, which also gives rise to free radicals. Another is alcohol, which increase the lipid peroxidation, which also produce free radicals. What is the harmful effects of free radicals? Free radicals can affect all the biomolecules of our body. First and foremost is protein. The free radicals damage protein by cross-linking aggregation. As a result, biological activity of protein is reduced. Achha, then হচ্ছে lipid. Lipid main component কি? Lipid কি তৈরি করে আমাদের বডিতে? What does lipid produce in our body? Cell membrane produce করে. Achha, lipid, another process, another PUFA. What is PUFA? What is PUFA? PUFA ki? Achha, PUFA is the highly susceptible to free radicals. Lipid peroxidation damages the cell membrane, cells and tissues, and thereby it causes various diseases. Another is carbohydrate at physiological pH, oxidation of monosaccharides produce free radicals. Then the nucleic acid more prone to free radical damage caused by the free radicals. That's how the free radicals damage the nucleic acid. It causes DNA break, তারপর হচ্ছে fragmentation of bases, such damages associated with cytotoxicity and mutation. Next, I am coming to free radicals and disease. As free radicals affects all the biomolecules of body, that's why many diseases are associated with free radicals. First and foremost is cardiovascular diseases. Have you heard the LDL, oxidized LDL, which is associated with atherosclerosis of the coronary artery? Then cancer, nucleic acid is damaged by the free radicals. That's why free radicals causes mutagenicity and cytotoxicity. Free radical inactivates some pro-oncogene which give rise to cancer. What is the function of procarcinogens? What is the function of procarcinogens? Next I am coming to inflammatory disease. Have you heard the name of RA? Rheumatoid arthritis? Yes. Rheumatoid arthritis is an autoimmune disease and inflammatory disease. It is also produced by the free radicals. Diabetes is another cause, disease produced by the free radicals. How? Due to production of free radicals, the islets of pancreatic cells are damaged and the insulin secretory cells is reduced and the insulin is reduced. That's why diabetes occurs. Now I am coming to another disease, male infertility. Male infertility is also associated with the free radicals. Free radicals reduce the sperm count and its mobility and viability. Aging process is also associated with the free radicals. Free radicals increase the aging process. Free radicals also plays key role in cataract formation, Alzheimer's disease, Parkinson's disease, multiple sclerosis, cirrhosis of liver. Have you heard the name of Parkinson's disease? Yes. As free radicals is produced by the various biological process in our body, that's why body has a defense mechanism by which it can neutralize the action of free radicals. Okay, what is the name of that defense mechanism? That is antioxidants. Antioxidants, what is the definition of antioxidants? Antioxidants are substances that neutralize or inhibit the oxidation of free radicals. There are various antioxidants in our body. Okay. According to the location, the antioxidants are classified into three groups. Plasma oxidant, antioxidant such as carotene, beta carotene. Have you heard the name of beta carotene? What is the function of beta carotene? Imparts color of fruits. It is also an antioxidant. Plasma antioxidants such as beta carotene, ascorbic acid, uric acid, ceruloplasmin. Second, cell membrane antioxidant is alpha tocopherol. What is the tocopherol? What is the vitamin known as tocopherol? What is the vitamin known as tocopherol? What is the vitamin known as tocopherol? Hey, which vitamin is known as tocopherol? Tocopherol, vitamin E. Third is intracellular antioxidants. Superoxide dismutase, catalase, glutathione peroxidase. According to the nature and action of antioxidant, the antioxidants are classified as enzymatic and non-enzymatic. Enzymatic antioxidants are superoxide dismutase, catalase, enzymatic antioxidants are four enzymes are associated with enzymatic antioxidants. First one is superoxide dismutase. Second one is catalase. Third one glutathione oxidase. Fourth one glutathione reductase. These are the reaction how they neutralize the free radicals or their antioxidant properties. Okay. What I say? Next, I am coming to non-enzymatics. Non-enzymatic antioxidants are divided into two parts. এক হচ্ছে nutrient antioxidant. Have you heard the name of vitamin C and vitamin E? What is function of both of them? Main function is antioxidant. Vitamin E resides present in cell membrane and thereby it neutralizes free radicals like superoxide, hydrogen peroxide and hydroxyl ion. Another nutrient antioxidants as ascorbic acid, beta carotene, selenium. Our metabolic antioxidants are glutathione, albumin, bilirubin, uric acid. The main purpose of antioxidants is to reduce the or inhibit the free radicals or neutralize the free radicals and thereby make free or reduce the disease burden of the body. Okay. What is the, have you any idea about the relation between vitamin E and vitamin C? C in relation to antioxidant property. কোনো আইডিয়া আছে? No idea. Vitamins alpha tocopherol is converted into alpha tocopherol free radicals, which is a reduced form of alpha tocopherol, and inactive form of vitamin E, which is reduced to active form alpha tocopherol by the action of vitamin C. Okay. It is all about ROS and antioxidant.